So our last abstract for this session is going to be provided by Dr. Matt Slief from University of Alabama in Birmingham. The title of his abstract is a pilot study of patient-reported outcome measures among individuals with histiocytic neoplasms.
Thank you, Dr. Go. And as Dr. Go said, my name is Matt Slief. I am a second year internal medicine resident at the University of Alabama at Birmingham. I'm very thankful for this opportunity to present my research on behalf of the Mayo Clinic, University of Alabama at Birmingham Histiocytosis Working Group. I'd like to start my talk with an introduction, starting with a discussion of health-related quality of life, and then talking about the related topic of patient-reported outcomes, then briefly touching on the research methods, results obtained, conclusions, and next steps. So broadly speaking, health is influenced by individual and environmental characteristics such as age, sex, culture, and access to healthcare, as well as biological factors such as predisposition to disease. Derived from these influences, the concept of health-related quality of life is a multidimensional construct, which itself includes symptom status and treatment effects, functional status, and patient perspectives regarding the quality of their health and life. So not only does understanding health-related quality of life help us identify symptoms early on and help us to appreciate our patients' well-being in a general sense, but it's also shown to have prognostic significance. For example, in other cancers, there's been shown to be a correlation between baseline fatigue and overall survival. However, this has not yet been studied in histiocytic neoplasms. So how do we go about measuring health-related quality of life? It starts with going over some definitions. So patient-reported outcomes are a subjective measure about how a patient functions or feels as a byproduct of their disease. It's important to emphasize that this must necessarily be obtained directly from the patient, as physician interpretation of these measures has been shown to be biased towards underrepresentation. And then patient-reported outcome measures are then simply the tool or instrument that is used to measure the patient-reported outcomes of interest. So our particular PROM was the Patient-Reported Outcome Measurement Information System, or PROMIS. This is a National Institute of Health initiative, which is designed to standardize patient-reported outcomes. It's been shown to be widely applicable, can be applied across any disease state. Some of the other benefits include the fact that it's efficient. It can be administered within a single clinic visit, as was done in our study. And it is reliable in the sense that it has been shown to correlate with older accepted legacy measures. So PROMIS adheres to the World Health Organization tripartite model of health, which ascribes health to consist of physical, mental, and social domains. And our specific version of PROMIS was this PROMIS 29+2 profile version 2.1, which assesses these domains based off these 9 subdomains shown. And here's an example of the short form, which one of the patients would have filled out. It's specifically assessing the domains of physical function and anxiety with the prompts shown below. And here's an example response. And then when you submit the PROMIS short forms, you will then get a T-score output. It's worth emphasizing that the T-score itself, a higher T-score value, always indicates more of the domain being assessed. So, for example, in a symptom-based domain, such as pain or fatigue, a higher T-score indicates a higher symptom burden. Whereas in a functional domain, such as physical function, a lower T-score would indicate more functional impairment. And then these T-scores are calibrated against the general population mean with a mean of 50, the general US population, I should say, mean of 50 and a standard deviation of 10. And then for each domain, a mean deviation of plus or minus 3 was considered to be clinically significant. And this is based off a prior Journal of Clinical Oncology study. So beyond just assessing individual domains, you can also use PROMIS to assess summary scores. So using the domain shown, we assessed physical health and mental health summary scores. And then further highlighting the flexibility of PROMIS, you can calculate a PROP-R score. And this is essentially just a measure of overall health. And the interpretation of the PROP-R score, a score of negative 0.022 is the lowest possible value. This is a state that's worse than dead, as a score of 0 is dead. A score of 0.52 is the general US population mean. And then a score of 1.0 is the highest possible score, indicating full health. And then a difference of plus or minus 0.04 from the US population mean is considered to be significant. So a brief overview of our research pipeline. We selected individuals with histopathologically proven histiocytic neoplasms from the two large academic referral centers, Mayo Clinic and University of Alabama. The dates were August 2022 through December 2022. Individuals were administered the specific version of PROMIS, and analysis was conducted as discussed. Covering our demographic characteristics, the total number of individuals was 47. Our median age at diagnosis was 52. And then we included individuals with diverse histiocytic neoplasms, including ECD, LCH, RDD, and a single individual with ECD, LCH overlap. And we had predominantly multi-system organ involvement in our study. And covering the specific organs involved, you can see we had predominantly bone and skin, although noticeably various other organs were involved, notably CNS and pituitary. So now let's dive into the specific T-score results. Looking at our PROMIS scores in Erdheim-Chester disease specifically, we saw impaired physical and cognitive function, as well as a propensity towards increased pain. And notably, these individuals did not have any difficulty with sleep. And I should add that this scale itself, the value of 0 is essentially 0 to the general US population mean. And now looking at those with Langerhans cell histiocytosis, you see many more domains affected in these individuals. In addition to those domains affected in ECD, you also see fatigue and anxiety implicated. Finally, our individuals with Rosai-Dorfman disease had certainly fewer domains affected. You can only see anxiety and pain intensity. And then we asked the question whether specific domains affected might be influenced by the organs involved. So here you can see an organ involvement analysis for CNS, not including pituitary, as well as the pituitary alone. In both organ involvement, you see impairment in physical and cognitive function, as well as anxiety. But in CNS alone, you only see impairment in social roles and pain interference. And pituitary, you see impairment in fatigue. And then we also looked at the summary scores. In individuals with LCH, you see impairment in the composite mental and physical summary scores. whereas in individuals with ECD, you only see impairment in the physical summary score. And finally, we use the PROPR measurement as a measurement of overall health. And again, the general US population mean here is 0.52. And we see across the board in all the diverse histiocytic neoplasms, impaired overall health. So in conclusion, people with histiocytic neoplasms in our pilot study report impaired health-related quality of life. The promised domains associate with disease subtype and organ involvement, specifically CNS. It's imperative to expand the study enrollment and include longitudinal data as well. And we anticipate future study will allow us to analyze the impact of chronic health conditions, disease status, and treatment effects. Thank you.
Great talk. Thank you for the great presentation. One question is that, there is a disease, it's related parameters that you have seen. How much does the cost of healthcare in these patients influence the psychological parameters here and in terms of outcomes? Have you seen into it, or is there, something that, how much weightage would you give to that cost of healthcare in these patients?
I might defer that question to Dr. Gore.
Yeah. Is the question about how much these domains, yeah.
They're reporting anxiety, depression. Is it related to the disease itself?
Yeah. So, yeah, we don't know. That's a very good question. In other cancers, it's been looked at that, financial toxicity does impact a lot of things, a lot of domains of health. So we are not there yet, but it's a good, first step to examining these things. The next step will be to look at clinical factors that we know of, treatment factors. We started a little bit diving into the organ involvement, but yes, then we have to tease out whether this is the treatment side effects, and then other effects. But yeah, that's the cost question is very important to explore.
That was very interesting. Thanks. The findings in LCH, that makes me wonder whether those were people who have sort of been through a bunch of chemotherapy and now they're sort of post-treatment. So I think that one thing you'll do when you maybe get more patients is look at where they are in their treatment trajectory, because that in a cross-sectional way is difficult to interpret. I don't know if you have any sense of where the different subtypes were in treatment. Someone with LCH is more likely to have, had their chemotherapy 5 years ago kind of thing than an ECD patient.
Yeah, absolutely. I do think that's a very important next step. We didn't, in this pilot study, we didn't include that analysis, but I absolutely agree. And I anticipate with Dr. Goyle's future work, he will be including that.
We have 3 flavors, in LCH is one of the pulmonary LCH. A lot of domains were affected there. I mean, we have seen that anecdotally. But then there were childhood survivors, a couple of them of LCH, especially the ones with skull disease, that we say don't take it all out. And, the pain and fatigue and the pain was huge component in those patients. Clinically, I don't know how to help them. So I'm like, let's look at this. So, and then the third, I'll tell you, like, only a couple of patients were heavily, like a lot of chemo, who received a lot of chemo. But in LCH, we are seeing, a lot of domains affected regardless. I don't know, but it's too early right now to comment, but we have to look at that for sure. And if Ken has any other thoughts on adults with LCH and, anecdotally or.
Well, it's interesting. Several kids I've seen with big surgical resections have had a lot of pain that went on. and the neurosurgeons can't explain it. And of course, we've all seen adults who have fatigue that drags them down for years and years. And I think that's one of the biggest questions we need to answer, is how to figure out what's the cause of it and what to do about it. So I think this is a great first step, and hopefully more will be done.
So this is fascinating work. Quick question, your PROs, they do not incorporate the standardized scales of depression and anxiety, correct?
That is correct.
Yeah, so I think that's getting back to what Ken was saying. I think the PROs are a great start. We do this all the time, but then correlating these with objective measures, if that's the word you want to use for these scales, formal sleep studies. I have seen in other CNS inflammatory disease states that sometimes that's the only way you get down to the etiology of what's causing symptoms like fatigue, pain, cognitive dysfunction, is correlating some of the PROs in patients' experiences with formal testing, and that can give you insights that you may not get, no matter how much time you spend with a patient, and no matter how let's say insightful or a careful historian you may think you are, because it's just that in my gestalt, it's these issues are just that complicated.
Thank you very much for that point.